Welcome to tonight's masterclass. My name is Paul Ogilvie, and I'll be your moderator for tonight's masterclass. We have an excellent masterclass faculty with us to discuss the topic of why cervical arthroplasty is not the gold standard. This is a particularly timely subject as there are more devices entering the US market every day, and we are seeing publications of 7 and 10-year data as follow-up. I'm really pleased to introduce our masterclass faculty, starting with Dr. Jessica Adlin. Dr. Adlin is the Chief of Spine Surgery at Newton Wellesley Hospital, Assistant Professor of Orthopedic Surgery at Tufts University Medical School, a spine consultant at Boston College Athletics, and Medical Director of the Newton Wellesley Spine Center. Also joining us this evening is Dr. Neil Wright. Dr. Wright was recently the Herbert Laurie Professor of Neurosurgery and Director of Neurosurgical Spine Fellowship at Washington University School of Medicine. In 2020, Dr. Wright decided to leave Washington University to create a patient-centric cervical practice with neurosurgery at St. Louis. Dr. Wright is an early adopter of arthroplasty and well known for his focus on the treatment of cervical spine disease. And lastly, we have Dr. Michael Heisey. Dr. Heisey has served as president of Texas Back Institute from 2010 through 2013. He's also served as the vice chairman for the Department of Surgery at Denton Regional Medical Center, chairman of the board of managers for Texas Health Presbyterian Hospital, Flower Mound, and vice chairman and of the governing board at the Texas Health Presbyterian Hospital, Flower Mound. He also serves on several committees for national medical societies, such as North American Spine Society. He is regularly called on to present research papers or symposia at National Medical Society meetings. Thank you to all for joining us for this distinguished faculty. Now to our audience, please make sure to use frequent use of the question and answer button at the bottom of your screen. Please submit any questions and we will do our very best to address all questions that come in to our panel of surgeons. Starting us off this evening will be Dr. Jessica Adlin and her talk, ACDF, the gold standard.
Hi, everyone. I'm Dr. Jessica Adlin. Thank you so much for that introduction. I'm looking forward to talking to everyone today about ACDF and whether or not this is really the gold standard for our approach to cervical spine disease. These are our disclaimers. So surgical management of cervical patients, the primary goal is to decompress the neural structures. We have several options, foraminotomy, laminectomy, corpectomy, ACDF, many different approaches to address the problem and actually achieve the goal of the surgery. Oftentimes we think of ACDF with the secondary need of restoring height or any anterior cervical procedure because we can put something in the disc space to actually distract the disc space. And this allows for indirect decompression of the neural elements as well as direct decompression. So there are those two goals that we want to think about when we're putting in something in the inner body space, whether that be a standalone plate, a standalone ACDF device, an anterior plate with a bone graft. But fusion is not the only option. And that's really what we want to talk about. You know, we think of ACDF as the gold standard, and certainly there are other things to think about depending on what your patient has, you know, how old they are, what the pathology is, how many levels are involved. And Dr. Heisey will be certainly going over a lot of that data as well. So ACDF is a very successful surgical procedure. We've been doing this for 50 plus years. We have a lot of clinical experience, a lot of data surrounding this. And a lot of surgeons say, but ACDF is such a tried and true, predictable procedure. Why would I want to do anything else? It's accepted, the technique is comfortable, the results are consistent, and we're able to really achieve all of those goals of disc removal, getting rid of all those osteophytes, restoring height, and restoring stability. And carpentry is really important with the ACDF, as we all know. So another case here that I just want to bring to your attention as we go through the next few slides. So this is a 57-year-old male. He's now 6 years status post to C5-6 ACDF. He presents with, just for follow-up, he's having some intermittent stiffness, neck discomfort, otherwise doing well, no radicular symptoms, no neurologic symptoms. So we get these x-rays on him, and you can see where this ACDF surgery with a bone graft and an anterior plate with 4 screws. Worked great. He has a solid fusion, it's stable, and he doesn't have any neurological symptoms. So this was a great operation for this patient, many would argue. So the question is, what is he having neck pain from? Well, it's really hard to say. It could be muscular, it could be, adjacent level problems, it could be postural, it could be a lot of different things. So we will work this up, but the point is that this approach that he had for this problem, this initial problem, worked really well for him. So moving on to some of the clinical results for ACDF, we talked about, what is needed for the bony fusion. If you look at this review of these publications during the IDE trial, so it's 24-month follow-up comparing single level total disc replacement to an ACDF with a plate. And if you look over here on the right, the fusion rates are pretty consistent. So, basically 90% or greater. And the NDI scores consistently decrease post-op. So patients do clinically improve. Their fusion rates are consistent. So people may ask, well, why would we move from ACDF to disc arthroplasty if we have this tried and true procedure? And I think that's one of the biggest things we hear often when we have this debate. Clearly with ACDF, one of the biggest things to talk about is the long-term disadvantages. And I think this is probably where we delve into the details of how arthroplasty may be such a great alternative to ACDF, especially for younger patients. So when you look at an ACDF, you're obviously fixing one segment, you're getting mechanical stability, you're taking away motion. So the loss of motion at the fused level is compensated for by significant increase in flexion and extension, lateral bending, and axial rotation at the adjacent segments. So Schwab had that paper in 2006. And then Hillebrand's paper, very famous. We know that 26% of cervical fusion patients have symptomatic adjacent segment disease within 10 years. So that's big. A lot of times we say, well, someone may have adjacent level disease radiographically, but does that really correlate with their symptoms? And this paper shows that a pretty significant percentage of people have symptomatic adjacent level disease. And the incidence of ACDF, of ASD in young ACDF patients with trauma, similar to ACDF in older degenerative patients, it's the same. So this suggests the role that there's a biomechanical effect of adjacent segment disease. This was Goffin in 2004. These patients who are younger and have a longer lifespan to, allow those discs to degenerate. So the point is it doesn't matter how old they are, they're still going to have that adjacent segment disease in the same amount of time. And of course, because they're younger, they may end up requiring further intervention down the road. So 23.7% of ACDF plus plate patients developed moderate to severe ossification at the adjacent level. So these are big percentages. We're not talking 2 to 3% of people getting adjacent segment degeneration and ossification. So if you think about it, this is probably leading to a higher reoperation rate with ACDF. So adjacent level degeneration and reoperations, this is the IDE clinical study comparing the ACDF with the total disc arthroplasty. And this has shown increased range of motion or degeneration at the adjacent levels with ACDF. Several papers have shown that. We do see that increased range of motion and degeneration. Therefore, the reoperation rates are 2 to 6 times higher with ACDF if we look at these clinical studies. So that's actually, again, a really big deal. And I think, short-term early results, ACDF is extremely powerful, successful operation. But when we look down the road, that's where we really start to see the changes and start to think about, is this really the better option for these patients? This was actually from the instructional course lecture in 2009 for the Academy, looking at ASD after cervical fusion. And this is just a good cartoon of kind of what happens. So you see this disc herniation here, probably a degenerative disc there. There's a anterior plate fixation with a bone graft. And over time, you see that there's a disc problem at the level above. And that's kind of how we describe adjacent segment disease. And so the studies comparing the effects of disc arthroplasty and ACDF on cervical spine biomechanics have shown that ACDF does certainly result in increased motion, stress, and disc pressure on the adjacent levels. So there's clearly a theme here with all of this data that we review and pull together. And studies have reported that the incidence values for developing ASD after cervical spine surgery ranged from, again, 6.7 to 25.6 at 10 years. And, I quote these things to my patients when I'm talking to them, and I certainly do ACDF still often, but it's really about educating our patients and making sure that they know what the differences are between ACDF, disc arthroplasty, why we would recommend one over the other, and help them to kind of make a decision based on what we're informing them of. And the incidence of symptomatic disease after ACDF may be higher, when we talk about radiographic evidence versus symptomatic. And there's also the patients who have disc degeneration prior to their ACDF. So they have their ACDF at C5-6. They already have some degeneration at C4-5. And so the question then becomes, is that disc going to degenerate even further more quickly, or what happens there? So, we don't know yet. I think we still have a lot of work to do in this space, but we talk about whether or not the clinical implications are speculative or really teasing out radiographic versus clinical data. So thank you. I will turn it over to Dr. Heisey now for discussion of the next topic.
Thank you, Dr. Adlin. That was excellent. In particular, I'm reminded of the landmark research by Dr. Hilbrand and the fact that 26% of people with a fusion will have symptomatic adjacent level disease. Our next speaker is Dr. Heisey, and he will talk about Mobi-C, a little bit about the history and the design.
Thanks, Paul, for the introduction. It's my pleasure to be here to talk a little bit about Mobi-C's history and design, and then some of the data behind Mobi-C. This is your standard disclaimer coming from ZimVie, the new company that I'm sure you've all had explained to you by now. Mobi-C cervical disc replacement is done to obviously preserve motion. Mobi-C is designed around a mobile bearing platform, and it's pretty easy to put in that it has no keels, no screws, no secondary fixation. It's held in place initially by a row of teeth on the sides of the device that are angled to prevent migration. And it has a titanium and hydroxyapatite plasma spray on the surfaces to hold it in place long term. It's been shown to have clinical superiority over ACDF at all time points in the 2-level subset of the study. It is a simple procedure, and again, no keels or anything that would take away bone, so it does spare bone, and it does restore physiologic motion, and it has been shown to reduce the average rate of adjacent segment disease with a nominally lower rate of subsequent surgery. We did then go back and look at the 10-year outcomes of the 1 and 2 levels Mobi-C study, and that was published recently, and I'd like to review some of the data from that study. We do know that short and midterm studies have demonstrated that Mobi-C is effective to treat cervical disc degeneration out to the 7-year time point. But once we completed the 7-year study, we wanted to re-enroll a subset of the patients to follow them all the way out to 10 years. So the purpose of this subgroup study was to examine the 10-year outcomes of a multi-center trial with cervical arthroplasty in the 1 and 2 level situations. The initial study was a prospective multi-center randomized FDA IDE clinical trial comparing cervical disc arthroplasty to ACDF at 1 or 2 contiguous levels. So there weren't any skip levels in the study, and the levels looked at were between C3-4 and C6-7. The primary inclusion criteria included disc degeneration refractory to non-surgical care with primarily radicular complaints. They could not have purely axial back pain, and they could not have had prior cervical operations. The follow-up in this study was extended out to 10 years for consenting patients at 9 of our highest enrolling centers in the original IDE study. 17 patients were looked at from a distance, and their adverse events, reoperation, and patient-reported outcome info was gathered remotely, so they weren't directly evaluated in clinic. At the 10-year follow-up, there were 187 of the 231 eligible patients available for evaluation, so that's 81% at the 9 sites, with a mean follow-up of 10.2 years, and the max follow-up was 11.2 years. X-rays were obtained by the 170 patients that did make it to clinic, 73.6% at the 10-year time point. And this included 62 subjects in the 1-level arm and 108 subjects in the 2-level arm. The things we looked at were the standard things we look at for any sort of evaluation of cervical disc surgery success, including VAS, neck and arm pain, neck disability index, neurologic status, patient satisfaction, secondary surgeries. And then we also looked at some radiographic outcomes, including segmental range of motion, inflection extension and lateral bending, global range of motion from C2 to C7, sagittal alignment, heterotopic ossification, and we evaluated that using an outside reviewer looking at it using the McAfee and Marin classifications, and adjacent segment pathology, again, using an outside evaluation company using the Kellgren-Lawrence scale. We did want to know, as we started this study, is our subgroup, the 10-year cohort, comparable to the entire IDE cohort? So we did compare all of the entrants into the study to the 10-year study cohort. And obviously the sites are different, 9 sites versus 24 sites. And we have a lower number of studies, but you can see going into the study, at least, all of the patients were very similar, with ages very similar, no difference in gender, body mass index, race, preoperative neck disability index scores, arm pain scores, or ability to work. All of those were not statistically different. Similarly, at the time of surgery, we wanted to make sure that nothing different happened, like we weren't using surgeons who were going faster or having lower or higher blood loss in this subgroup. And again, we see that during the surgeries, the surgeries went about the same, with very similar amounts of 1 and 2 level procedures. The treated levels were similar. The amount of 1 and 2 level surgeries and the number of levels that were done were very similar. Estimated blood loss was similar, and length of hospitalization post-operatively was very similar. And again, return to work was similar. So we did feel like the subgroup was going to be very representative, and we could draw conclusions about the whole group by just looking at this subgroup. So looking at the data, VAS neck pain, looking at the difference between the 7 and 10-year data, there was an improvement in the two level group that was actually statistically significant. It's not showing on the slide, but it's statistically significant. And though there was an improvement in the 1 level group, there weren't enough patients to actually get to statistical significance. But I think the take home from this is that the neck pain improved post-operatively, and then that improvement was maintained through all time points, even out to 10 years, and it certainly didn't worsen after 7 years. So we were very comfortable that the neck pain was improved and that improvement was maintained. Similarly, arm pain in the 1 level arm showed no significant difference between the 7 and 10-year time points. And then the 2 level arm, similarly, the improvement was maintained and in fact was statistically different, although clinically maybe not so important. It's a small amount of VAS change, although it did turn out to be statistically better in the 2 level group between the 7 and 10-year time points. But you can see on in graphical form that the VAS arm pain improved rapidly after surgery, and that improvement was maintained. And I think that's the take-home point of a successful operation for cervical pathology. Similarly, looking at neck disability index, there were no statistically significant differences between the 7 and 10-year time points in either the 1 or 2 level study. And again, that the neck disability index improved immediately after surgery, and that improvement was maintained. Neurologic deficits, we didn't see any significant amount of worsening of neurologic deficits throughout the study. And in fact, the neurologic deficits tended to improve immediately post-op and maintain their improvement throughout all time points. When we looked at the motor evaluation, there was, again, definite improvement immediately post-op, and that was, again, maintained all the way up through the time points. And there was no worsening between the 7 and 10-year time points. But there was a bit of creep of a small amount of people that worsened. And I think that's a natural progression of disease and adjacent segment disease that's causing it. But there are a small amount of progression of neurologic deterioration over the 10-year time point, but very small compared to the amount of patients that had deficits going into the study. So now looking at range of motion, we're looking at the 1 level study on the left, as you're looking at the slide, and in the middle, we look at the upper of the 2 level and the lower of the 2 level. And you can see that range of motion is maintained in flexion extension all the way out to 10 years. It's a little bit improved in the 1 level group compared to preoperatively, but in the 2 level group, it's in general maintained through all time points. Looking at the same thing, but this time lateral bending, you can see that the range of motion is maintained through all time points with no worsening, no loss of range of motion noted as time went on in the study. So good maintenance of range of motion in both flexion extension and lateral bending was maintained by the MobiC. Global range of motion, this is again C2 to C7. You can see that global range of motion was also maintained in both the 1 and 2 level groups all the way out to the 10-year time point with no real change between the 10 and 7-year time points, or 7 and 10-year time points. Sagittal alignment, you can see that that was actually improved immediately post-operatively, and that improvement was maintained. Improvement meaning going to more lordosis versus more kyphosis. And you can see that that was maintained through all time points with good improvement. So it's very good that MobiC, even though we don't think of it as a deformity correcting type of procedure, that we were able to improve this sagittal alignment at least to some degree. One of the main motivations for doing an arthroplasty versus a fusion is that we might be able to prevent adjacent segment disease. And so we wanted to see how did adjacent segment disease do in the arthroplasty group compared to the previous time points. So you can see that as time goes on, there's very little worsening of the adjacent segment degeneration in the 1 level group, with very few grade 4s, which are the black, the grade 3s, grade 2s, grade 1s, and grade 0s. So very, very little worsening of the adjacent segment degenerations, and particularly the very high levels of adjacent segment degeneration. We see very similar results and perhaps even better in the 2 level group. And that actually goes along with what I'll show you later in the Alan Hillebrand study, that the original study showing that 2 levels actually did a little bit better in terms of adjacent segment disease than 1 levels even did, even in that early study. But the main take home from this is that in between the 7 and 10-year time point, there wasn't worsening of adjacent segment degeneration. Now looking at subsequent surgeries, both at the index level and at the adjacent level, we can see that those did not increase much. There was a small number of patients that did require subsequent surgeries at the index and adjacent level. Primarily at the index level, if it happened at the index level, it tended to be earlier. At the adjacent level, it tended to actually be later, but there was very little between the 7 and 10-year time points. Device-related adverse events identified during that time frame. There were a few that were identified as possibly related to the arthroplasty device, 6 cases of heterotopic ossification, 2 of subsidence, 1 patient with a decreased reflex, 1 patient with adjacent level kyphosis, 1 patient with neck spasms and decreased range of motion, but none of these adverse events have required surgical intervention at the time of follow-up. So our conclusions were that at the 10-year time point, both 1 and 2 level arthroplasty patients continued to have a significant improvement of pain scores, NDI, neurologic deficits, range of motion, sagittal alignment when compared to baseline. Progressive heterotopic ossification was minimal from 7 to 10 years. Radiographic adjacent segment degeneration was not significantly worse compared to 10 years. There were no device-related subsequent surgeries reported between 7 and 10 years. 98.4% of the patients were quite satisfied with their disc replacement surgery. So we concluded that total disc arthroplasty was safe and effective as a surgical treatment for 1 and 2 level cervical disc degeneration up to 10 years. Now a little bit about adjacent segment disease. How does cervical arthroplasty affect that? The very commonly referenced study by Alan Hillebrand and Henry Bowman talked about the rates of symptomatic adjacent segment disease after cervical arthrodesis, and reported that more than 25% of all patients encountered symptomatic adjacent segment disease up to 10 years after cervical arthrodesis. Risk factors included single-level arthrodesis involving the 5th or 6th cervical vertebra and pre-existing radiographic evidence of degeneration at the adjacent levels. The findings suggested symptomatic adjacent segment disease is the result of progressive spondylosis, and patients should be informed of the substantial possibility that new disease will develop at an adjacent level over the long term. And that's really one of the primary motivators for us to think about arthroplasty as an alternative to fusions. We do know cervical fusions do very well, but if we can prevent the adjacent segment disease, we're going to prevent downstream pathology. So how did we do? Well, in the MobiC study, we saw lower rates of adjacent segment disease all the way out to the 7-year time point, with about, in the 1 level study, about 43.8% of MobiC compared to 63% of ACDFs developed adjacent segment radiographic changes at the inferior level and 40.4% of the Mobi-C patients compared to 65.1% of the ACDF patients at the superior level. Now, there is going to be a normal rate of degeneration progressing over time, but we think we've at least decreased it compared to the ACDF. Now, bear in mind, this is not symptomatic disease, as Dr. Hillebrand had talked about in his study. What we're talking about is radiographic changes. So it's a little bit different than symptomatic adjacent segment disease. Looking at the 2-level study, it was even actually better for the Mobi-C with 30.3% compared to 67.7% in the ACDFs at the inferior level and 37.5% for the Mobi-Cs compared to 73.7% for the ACDFs at the superior level. So we saw that the risk of adjacent segment degeneration and subsequently risks of adjacent segment surgery was 2.5% and 3.5% greater for the 1 and 2 level disease processes respectively when treated for ACDF versus cervical disc arthroplasty. Said another way, ACDFs had roughly 3 times greater risk of adjacent segment surgery than arthroplasty. So these are the factors that turned out to be important in the logistic regression. If the treatment was fusion, there was a significant risk, about a 2.4% odds ratio that the patient would have a subsequent surgery. With age less than 40 was also a risk factor. Interesting, that's not something that I would have actually expected. Postoperative neck pain does make sense. Patients with more symptoms are more likely to need more surgery. Patients with arm pain improvement that was not as good were more likely to have surgery down the road at an adjacent level. And then in the ACDF group only, not the Mobi-C group, we noticed that noted that the pre-op C2 to C6 angle was a risk factor for adjacent segment surgery. So if they were kyphotic, more kyphotic, and if they have pre-op kyphosis that is greater than 0 or less than 0, that was also considered a risk factor. So a kyphotic angle would be a negative lordosis angle. So the conclusion of this was that in the Mobi-C study, total disc replacement patients had a significantly lower risk of subsequent surgery at the adjacent level compared to ACDFs. Younger patients, interestingly, had an increased rate of adjacent segment surgery. We thought that possibly that was due to higher activity levels and a higher demand, similar to the reason we see that hips and knees tend to not last quite as long in the arthroplasty literature. And the patients do have a greater desire to increase or maintain their activity levels. We did notice that preoperative sagittal plane alignment was a predictor of adjacent segment surgery, but actually only in the ACDF groups. Mobi-C was relatively insensitive to kyphosis. If the patient was kyphotic or lordotic, we did not see a higher rate of adjacent segment disease, but definitely if the patient was kyphotic, they had a higher rate of adjacent segment disease if they had an ACDF. These results support the hypothesis that elimination of motion in ACDF may lead to greater risk of adjacent segment surgery, whereas motion-sparing features of arthroplasty reduce the risk of adjacent segment surgery. Thank you.
Thank you, Dr. Heisey. That was excellent. In particular, the data regarding adjacent level degeneration, which suggests a 2.5 to 3.5 times greater risk with ACDF. And of course, there being no difference between the 7 and 10-year results on adjacent level disease with cervical disc arthroplasty. Our next speaker is Dr. Wright, and his talk, Mobi-C versus ACDF, tying it all together.
Thanks, Paul. So I'm here to talk about the third part of this seminar, and that's what's holding cervical total disc arthroplasty back. And as Paul mentioned, my name's Neil Wright. I'm a neurosurgeon. For 20 years, I was professor of neurosurgery at Washington University, and now I'm in private practice specializing only in the cervical spine. This is the disclaimer from ZimVie that I'm a paid consultant, and this information is of a general nature and doesn't represent or constitute medical advice. So far in this presentation, you've heard from Dr. Adlin about the risk of adjacent segment degeneration in cervical fusions, and that's largely based on the data from all the cervical arthroplasty studies. And you've also heard from Dr. Heisey about the advantages of cervical disc arthroplasty, especially with regards to adjacent segment degeneration. And then the question is, how many patients are actually getting cervical disc arthroplasty? And there's been some interesting background work on this. And this was a paper from the Spine Journal in 2008. So this is before cervical arthroplasty was really underway. But what this group, with Josh Auerbach et al., looked at was what was the prevalence of indications and contraindications to cervical disc replacement. They wanted to know how many of the patients who had undergone cervical spine surgery would have met those published inclusion and exclusion criteria for disc arthroplasty. So that was a retrospective review of nearly 170 consecutive patients who were having cervical spine surgery in either a university or private practice setting. And they all were receiving elective surgery after failing conservative treatment. So tumors and trauma were excluded from this. And what they looked at in that group of patients was first, what was the proportion of patients who had contraindications for cervical disc arthroplasty? So, and those were the published contraindications from the IDEs, such as spondylolisthesis, previous surgery at that level, active infection, instability, previous surgery, or previous fusions. So those were the published contraindications and which proportion of their patients had those contraindications. And then with the group who did not have a contraindication, they further wanted to identify the proportion who met the labeled indications. So that would be 1 or 2 level disease, consecutive levels, having either radiculopathy or myelopathy attributable to degenerative disc disease, bone spur, etc. And what they saw in this was that 53%, half of the patients, had a labeled contraindication. And then of the remainder, 43% met the labeled indications for arthroplasty. So their projections were that in their cervical spine population having elective spine surgery in those 2 settings, that 43% would qualify for cervical disc replacement. They also looked at then this number, the 4.2% of patients who would qualify if adjacent segment disease was included as an indication. So that's obviously off-label at present, but they said if you included those patients, it'd be an additional 4.2%. So if we have a paper showing that in an elective practice that 43% of patients should be candidates for cervical disc arthroplasty, is that reflected in the numbers who are actually receiving cervical disc arthroplasty today? And there's been some papers about this sort of echoing or looking at the timeline of disc arthroplasty. So Dan Rue, back in 2018, in the Spine Journal, was looking at trends of utilization or rate of disc arthroplasty in the United States. Now, this was based on the National Inpatient Sample Database, comparing the time period of 2006 to 2013, and remembering that disc arthroplasty really started coming online around that 2006, but it didn't really build with insurance approvals until some years after that. But if you looked at that database sample in 2006 of patients undergoing cervical surgery, by far there was a prevalence of fusion over arthroplasty. So 120,000 patients in that database compared to only 540 arthroplasties. And if you flash forward 7 years, there was a proportional slight increase representing probably growth of population, the number of ACDFs, 127,000, but there's a 3-fold increase in the number of cervical disc arthroplasty. So still dwarfed by the number of fusions, but we're starting to see some trends there and some momentum. Then if you look at the paper in World Neurosurgery in 2017, so this is actually came out the year before Dan Rue's paper, but it's showing a later time date. Just this one was faster to publication or acceptance, I guess. But they were looking at a different database. This was the database of the University Healthcare Consortium. So this is of academic environment, university healthcare, and looking at the rate of ACDF versus disc arthroplasty. And seeing that in 2012, 92% of patients getting a 1-level surgery were getting a fusion, and only 8% getting arthroplasty. 3 years later, you're seeing nearly a 50% bump in the amount of people getting arthroplasty, so going up to 13%. If you then look at more recent papers, so this is Vince Trainalis, came out in 2020 in the journal Neurosurgery Spine, looking at what's the real world utilization of this emerging technology. This is now the time period of 2009 to 2017. And they were a different database. This is the IPM market scan database. And this isn't percentage of each surgeries, but this is the rate of disc arthroplasty per 100 ACDF cases. So in 2009, for every 100 ACDF cases, there were only 5.6 arthroplasties. 8 years later, 2017, there was now 28.8 cervical disc arthroplasties per 100 anterior cervical disc infusion. So, a five-fold increase in that 8-year period. But even if we look at that 28 per 100 ACDF, that still is nowhere close to the 43% of patients suggested that would have been expected to meet the criteria for cervical disc arthroplasty. And what are some of the reasons that may explain that difference? Now, part of it, we had those papers are until 2017, so we may well see, and as papers come out showing utilization in 2019, 2021, I anticipate we'll see a higher percentage. But why, at least in 2017, are we still seeing these numbers lag behind? Now, one of the answers at the beginning was insurance payers. So if we look back when we started doing arthroplasty, and I'm sure everyone on the panels had this experience, and I'm sure everyone in the audience has had this experience, that even after they were FDA approved, there were a lot of insurance payers who, for some years, considered disc arthroplasty experimental and would refuse payment. Now, fortunately, that's largely changed. So almost all private and government plans will authorize a 1 and 2 level disc arthroplasty for those who meet the inclusion-exclusion criteria. And the 2-level authorization by a lot of the private plans is dependent on which disc device you're using. It has to be one that's FDA cleared for 2-level use. So insurance issue was certainly I think an issue at the beginning of this process and slowed the adoption, but that's really shouldn't be as much of an issue now for those people meeting the inclusion and exclusion criteria. Another factor may be reimbursement. For better or for worse, the reimbursement for a disc arthroplasty to the surgeon is less than a fusion. So we look at the work units of an ACDF, depending on how you're trying to get it billed for. It's your arthrodesis code, your instrumentation code. Then if you're using a standalone inner body separate to the plate using the 22853 code, some insurers will pay for that, some won't. But regardless, you have, even if they're not paying for the 22853 code, there's still a fairly significant difference in RVU units for a 1-level ACDF versus a 1-level disc arthroplasty. And if you look at 2 levels, that's magnified even further. So I would hate to say that that's a big cause why surgeons aren't doing as much disc arthroplasty, but we also have to recognize that we are getting reimbursed less for that device. But to be honest, I don't know of any surgeons who are making that decision based on what they're being reimbursed, but potentially that's an issue why disc arthroplasty rates aren't where we projected them to be. It can also be inertia, because even though there's a lot of people like myself who believe that cervical disc arthroplasty is a better surgery than an ACDF. An ACDF is still a really good surgery with great outcomes. And so it's hard to convince some surgeons that to move away from a surgery that has been their workhorse and has worked really well for them and their patients for 50 years. So just as a sort of a humorous aside, I mean, that's Newton's first law of motion, that an object or a surgeon's not going to change their surgical plan unless they're acted on by some force. And the better the surgery we're trying to replace, the more force it's going to take to change that decision. But even if all those issues were addressed, even if insurance wasn't an issue, and if reimbursement wasn't an issue, even if we were able to address all those concerns, is 43% really the ceiling of how many patients could benefit from cervical disc arthroplasty? And I would argue the answer is no. So if we look at some of that initial paper we already looked at of the prevalence of indications and contraindications, this is the 2008 paper in the Spine Journal. and they were looking at how many patients met the published inclusion-exclusion criteria. Well, what were the contraindications that they excluded patients from? Well, some, 13% were excluded because they were either less than 20 or older than 70. And that's because these were not part of the IDEs for most part. But does that mean someone who's 19 wouldn't benefit from a disc arthroplasty, or someone who's 71? Greater or equal to 3 levels? That was the vast majority. That was pretty much half the patients who had a contraindications because they needed 3-level disease. And quite honestly, in my practice, that's a common patient who has 3 levels of disease. Now, does that mean that person wouldn't do well with arthroplasty? Well, that's unclear. That's excluded because that's not part of the IDE studies here in the United States. Or if they have a fused adjacent segment, they've had a fusion in years past, and now they come back with an adjacent segment. Well, they're excluded as part of the IDEs. Or if they have axial neck pain alone, does that mean they wouldn't do well with arthroplasty? Well, that's unclear, but that's excluded because this was not part of the IDE studies. So if we looked at some of those, or if you look at other studies potentially done outside the United States, you see that there may be some benefit in those scenarios. So another paper by Dan Rue, this is out of AO Spine in 2018, they looked at, did a meta-analysis of these different papers out there, obviously showing that single-level disc arthroplasty has at least equivalent results compared to an ACDF with a reduction in secondary procedures. But when they looked at things primarily outside the US, there are studies not as powered well typically as the IDEs here in the United States, or not as robust, but showing, looking at multiple levels or hybrid surgery. And it shows that there's some evidence showing that that indication, a hybrid surgery or multi-level, may be effective. And then this was a great paper that came out by Pearson Unley and Dom Korick et al. In neurosurgery a couple of years ago. And they looked at pretty much all the studies of disc arthroplasty, both the US IDE studies, the US non-IDE studies, as well as the outside US studies. And this was a robust undertaking. So looking at just the outside US studies that they reviewed, and well, not to go into all of them in detail, but you can see that on some of these, they're looking at a 3-level disease, hybrid surgery or 3 levels, looking at hybrid surgeries. So there's a fair amount of evidence. Now, these maybe not as powered as much. These are maybe smaller numbers of patients, but these are still a wealth of data out there looking at multiple levels, more than 2 levels, or hybrid surgery. And their conclusion was that the outside US data indicates that disc arthroplasty might be viable for many of those patients who currently are necessarily obtaining a fusion in the United States because they fall outside those strict inclusion-exclusion criteria. So that's the patient with more than 2 levels or hybrid surgery. So I think with that, I think there is a potential of having more patients candidates, but it's going to take some further data, further experience, and further study to show whether to get those approved in the United States and to get those in an on-label fashion. So I think that wraps up where we are currently with the state of arthroplasty and the rate, and be interested in our subsequent discussion. Thank you very much.
Thank you, Dr. Wright. That was very interesting. In particular, I'm curious about that data that shows that 43% of ACDFs could have had a Mobi-C or an arthroplasty, but yet suggest only 20% do. I'm also interested in your hypothesis of the insurance approval, reimbursement, or inertia kind of being those primary causes holding arthroplasty back. But for now, I'd like to thank our master faculty for all their excellent talks. And we'll start the Q&A portion. And so for anyone in the audience, if they have any questions, don't hesitate to fire them in via the Q&A. We have a few questions here that we're going to sort of run by our faculty initially, and there are a few questions currently in the Q&A, and we'll start off with these. First off, I'm just kind of curious if any of the other panelists have sort of a different idea as to why arthroplasty is not performed at that 43% sort of rate that Dr. Wright had kind of mentioned, aside from those three sort of topics that Dr. Wright had suggested. Dr. Heise, do you have any other insight on that, perhaps?
I think he's really hit the main points. There is some resistance to accepting the data as it's presented. They feel like sometimes the data might be company sponsored and therefore subject to bias, and they don't want to do that. But I think in a lot of cases, that's just supporting their essentially their momentum. They're not getting a strong enough reason to change, the strong force to change it. So I think it's just part of the same thing. I think really Dr. Wright summarized it quite well. I think his faith is a little bit higher than mine, that there aren't some people that do it because of money, because I've literally been told after teaching Mobius and giving this reimbursement information that come back and tell me again about it when we get paid the same or more for this. Otherwise, I'm not doing it. I've been told directly that. So there are some that are that way.
Now, even despite the data being, somewhat overwhelming with regards to arthroplasty and adjacent leg segment, and the benefits for the patient, you're still hearing even today that the reimbursement is a significant hurdle, Dr. Heise?
I am, yeah, it is a significant hurdle. The RVU rates is the RVU rates. We are actually on an RVU based payment scheme, so it's very simple to figure out the difference in what I get.
Dr. Wright, do you hear that sort of routinely from your colleagues with regards to reimbursement as well? You have a similar sort of experience in your practice?
I mean, obviously, it's a concern about the reimbursement for it. But on the other hand, doing arthroplasty brings a lot more patients into your clinic. If they know you do arthroplasty, this is something that sells itself to patients. Patients seek me out specifically because they know I do arthroplasty. So even if I end up not doing arthroplasty with them, in some ways you could think of that reduced RVU for the arthroplasty almost as a loss leader, because it really generates a lot of volume, a lot of subsequent patients coming in.
Interesting.
That's absolutely true. Absolutely true.
This is a question actually specifically for you, Dr. Heise. For 3 levels, doing a cervical fusion and the adjacent level arthroplasty is something that Texas Back Institute has done with great results. What are your thoughts on that? Obviously, that is off-label, but I think we're talking about arthroplasty in general. So, Dr. Heise, can you speak to that at all?
Yeah, we do have some published studies showing very good results in these hybrid type constructs, as long as you are paying strict attention to the indications at each level and making sure each level is appropriately indicated for an arthroplasty. And sometimes one might not be, and then you would consider a hybrid or a fusion at that particular level, whereas there's still candidates for arthroplasty at the other levels. Again, off-label, and again, sometimes you get some reimbursement concerns with that. It's interesting though that when you look at the foreign data, there's a lot of data on hybrids, and that's really because their reimbursement environment is almost the opposite of ours. They insurances have to pay higher and the patients pay higher for the arthroplasty devices. So they try and kind of get the patient into the clinic or get them a cheaper operation by doing a hybrid fusion and 1-level arthroplasty. So it's interesting how the reimbursement has affected where the data comes from and what it is.
Dr. Wright, have you had any experience with that specific question? And I know they specifically mentioned Texas Back, but in your practice, have you had any experience with that? And if not, that's fine.
Yeah, I have had experience with hybrid, and I think there's a lot of indications where hybrid's appropriate. So if someone has significant degenerative changes at 1 level, perhaps a slight instability, and they have a soft disc above that, that'd be a great case for hybrid. My limitation is, unless, at least in our area, unless that's a government insurance or workman's comp, that's not an option, because most of the insurance carriers absolutely will not let you do a hybrid surgery at the time of the end of their surgery. Some of them are split. You can do, you can do the arthroplasty now and come back in 90 days and do a fusion. I've had some patients who want to do that, which to me seems really not ideal for the patient, but sometimes you have to play that game. But most of the insurance carriers that we work with, I'm just not able to get that approved.
Yeah,
I was fortunate enough to have one case where it was actually on label. I had a 6-7 soft disc, as you described, and C7T1 has a spondylolisthesis and needed to be fused, and so it was actually on label because it was not adjacent to a cervical fusion. So it all worked out to the letter of the law.
And it also changes, it seems, month to month with the insurance payers' policies as to how they view it.
Yeah, it's a bit of a minefield. There's no question at all. And
well, I'm an absolute believer in hybrid surgery. There's patients who've had previous fusions in years past now come back with adjacent segment degeneration, and they want an arthroplasty. And so doing a hybrid separated in time where they have a fusion at one point in time and years later having an artificial disc is a great idea in the right patient. Or doing, like Dr. Heisey just said, or the example I gave, doing it at the same surgery. If you took the insurance carriers out of it, I would do a lot more hybrids.
I guess it comes down to doing the right thing for the patient. And, just as a note, as a company, we don't promote off-label, but just as a theoretical discussion. One question we had in the Q&A, just for both of you and kind of your opinion, I'll start with you, Dr. Wright, is do standalone devices have sort of a lower adjacent segment disease rate than a plate and a fusion? I know that Dr. Rue had his study looking at the location of the plate relative to the annulus of the adjacent levels, but what's been your thought on that? What's been your clinical experience?
So I think there's two ways to answer that question. As you pointed out, there's been several papers showing that when the plate at the index surgery is longer and that plate is terminating closer to the adjacent disc space, that certainly speeds up the risk for adjacent segment degeneration. So if you have a device that doesn't have a plate, on the one hand, it is probably a reduced level of adjacent segment degeneration. Another more cynical take on that is I think the standalone devices have a lower fusion rate, period, than a plated fusion. And so if it's not fusing, you're probably not having as much stress on the adjacent segment.
Very good. Dr. Heisey, any differences you would say?
Oh, no, that's an interesting way of looking at it. I think a good way of looking at it. I think that the data is really not in. I've seen data on both sides of this actually showing that the adjacent segment rate was similar, and you've got to tease out the plates that were, I would say, less than optimally applied if you're really going to compare it properly. And I'm not sure that's been done to my satisfaction. I think you can get a good result with both types of devices is the bottom line.
Very fair. One other question that just popped in here that I'm going to start off, I guess, with you, Dr. Heisey. And I think this speaks more to sort of kinematics than anything else, but are the results of the Mobi-C generalized to all cervical disc arthroplasty designs? And how do you decide sort of which FDA-approved device you're going to utilize? Obviously, you do utilize Mobi-C, but are there some designs that you feel maybe meet certain patient characteristics and may be better in certain circumstances?
Yeah, I do use Mobi-C quite often. The data does tend to follow the same trends in terms of symptomatic relief, in terms of adjacent segment disease and that sort of thing. So I think to some degree, there's some generalizability. I don't know that they're poolable and they're all the same. I know there are different rates of heterotopic ossification depending on the device design. So that has been shown in actually fairly early studies. Some were a little higher HO than others, and Mobi-C was kind of in the middle or low middle of that range. I select my arthroplasty devices based on what I'm comfortable with putting in, and I know how to adapt it to a particular patient. There are patients where they're outside of the size range. A very petite woman, I might go with a different design, because Mobi-C goes down to 5, and there are some that are available at 4.5 that I might use in a very petite woman just to prevent issues, but more commonly the Mobi-C fits my needs quite well.
Dr. Wright, your perspective on that and kinematics?
Yeah, so I really agree with Dr. Heisey. I put the disc in that I have the best track record with in my hands and the least complications with, but I don't think there's a big difference in outcomes, or there's not really been shown any difference in outcomes between the different disc designs. Now, I'm fascinated, especially on LinkedIn, you'll see various spine surgeons who I respect, who will present cases and say how they did use one disc design at one level, and because another level had more degeneration, they would use a different disc there. So you're actually seeing 2 or 3 different discs being used in the same patient at the same surgery. Maybe I'm not that sophisticated yet. I don't really see, as of yet, I don't see a strong indication to use one disc over another based on individual circumstances on that patient. I'm open to be educated on that or have my my horizons broadened on that, but I really choose the disc that I have had the fewest complications with, and so for me that's been Mobi-C. I trust it.
So perhaps a topic for another masterclass. But I had a question for both of you, just sort of out of curiosity. Yeah, and I know both of you sort of arthroplasty is kind of your approach of choice. Let's say if a patient came into your practice who had radicular symptoms or cervical symptoms, and you sort of see them as an arthroplasty candidate until there's a very good reason to fuse them, and let's face it, the data shows that a lot of patients they would be better served with a fusion. But sort of at what time in your practice did that kind of flip from when you were looking for a candidate to when you tried to identify when you shouldn't do one? And Dr. Wright, I'm going to start with you on this one.
Yeah, sure. So at the beginning of this process, I mean, I was part of the FDA trials for several disc devices starting in 2001. At the beginning, it was really looking for that unicorn. I mean, that patient with a soft, healthy disc. And so you had to really be convinced you had a candidate for arthroplasty because it was a new technology and we weren't quite sure. I wasn't quite sure how it was going to work in the long term. But as I've gotten more and more comfortable with arthroplasty, you start pushing your own individual criteria, which patients you approach them on. So it was probably a good 5-6 years ago that my philosophy changed. Is, as you said, initially I would see patients think they needed a surgery, the default would be a fusion, and then I would look for reasons whether or not they were a candidate for arthroplasty or not. Now my thinking is very different. When they come in, my first thought is, are they a candidate for arthroplasty? Or why are they not a candidate for arthroplasty that I should go to a fusion? And the reason I think that way is also patients often think that way. Because if I start talking about a fusion, very early in that conversation, there'll be a question, why aren't I a candidate for arthroplasty? So I usually will approach it that way, that, I usually like arthroplasty, but however, for you, for X, Y, and Z regions, I don't think it's a good option. But I start off for the evaluation of the patient thinking, is there a reason why I can't do arthroplasty here, rather than is there a reason why I can?
Yeah, smartphones and Dr. Google has educated patients quite notably. Dr. Heisey, when did your thought process change? Is it similar? Was it different?
Well, it's similar. I think I was a bit earlier, but obviously I'm at TBI, where we have the Center for Disc Arthroplasty here, and we've been doing arthroplasty since you did 2001. I think Scott did one in 2000 when I was a fellow. So, or just after being a fellow, I guess I wasn't a fellow then.
Thanks for making me feel old there. Thank you.
No, I was.
I think we're all in the same boat.
I think
here.
I just started late. At any rate, probably started about 10 years ago, right as the arthroplasty devices started to be put on the market. I started looking for candidates, and then soon was seeing the benefits and seeing, well, if I can give that benefit to my patient, that's great. Not all of them are going to be able to receive the benefits of arthroplasty if they have significant facet disease, if they have osteoporosis, spondylolisthesis, all that, those are unfortunately fairly common. But I think I started just a bit early, but really along the same trends, just trying to give the patients the benefit of what I think is a better operation. And I know I might get paid a little less. I might get paid a little less. I still do just fine.
Very good. This is a question, and I think it somewhat speaks, Dr. Heise, I'm going to start with you because I think it somewhat speaks to some of the data that you presented in the 10-year study. The question is, what's been the experience with coronal imbalance in single level and 2-level Mobi-C and with other devices? I know that in that 10-year, and I think you presented some of the data talking about global balance and talking about sagittal balance, but maybe you could reiterate some of that for us.
Yeah, well, there's actually another little talk we've given occasionally and presented at meetings where we look at the effects of kyphosis relative to lordosis in a patient that receives a fusion and a patient receives an arthroplasty. And what we found, and I'll just reiterate what I said tonight in the recording, is that Mobi-C did fairly well. You were able to, in some cases, correct kyphosis really just by distracting the disc space if it was locally lordotic, but not in all cases. But even if you didn't correct the kyphosis, you weren't revising the Mobi-Cs at a higher rate because the patient was kyphotic. Whereas in the fusion patients, when you were able to correct the kyphosis, they did better. But if you weren't able to correct the kyphosis in the fusion patients, they did definitely poorer and had a higher rate of reoperation. So another way of putting it is the Mobi-C was relatively insensitive to kyphosis. If the patient was kyphotic, they still did just fine.
Very good. Dr. Wright, anecdotally, any difference in your practice, what you've seen?
Yeah. Well, I think the question was also about coronal imbalance there as well. So, I mean, you have to do a good release of these levels. And there's been a few times where post-operatively, I wasn't happy with my films, and looking back, it's usually if I'm doing a left-sided approach, it's usually I haven't completely released the right side of the spine because it's somewhat buried under the trachea and esophagus, and I haven't released that segment on that side as much as I should have. And then when you put it in, you see that you've developed now a little bit of a tilt at that level. So you have to make sure the level is released symmetrically for the Mobi-C. Now, those patients didn't have any untoward effect from it. It's just not the prettiest of X-ray where you see on the AP film, you see a little bit of a lateral tilt of the disc. But I don't think there's any difference between the device. No matter what you put in there, if you don't do a good release, it's not going to look pretty.
Yeah, it comes down to the carpentry, right? If that's not right, then the device isn't necessarily set off on the right start at the get-go. But not seeing any other questions in the Q&A, so I'll keep sort of one eye on that, and also just with respect to time. I want to thank our faculty for just a great discussion. Oh, pardon me.
One more just popped up there at the bottom.
Oh, excellent. Let me just fire right down to that. Thank you very much, Dr. Wright. And I might as well just fire this over to you, Dr. Wright. So do you see that reimbursement landscape changing over time for arthroplasty? If these devices lead to lower revision rates, better outcomes, and reduced costs to the system? What are your thoughts?
I would think it will. I mean, we have seen sometimes quickly, sometimes slowly, we've seen the reimbursement environment improve in terms of letting us do some things potentially off-label or currently off-label. I think as the insurance carriers see that, when they're paying us less to do this disc, and they could, so I think there will be a slow creep. I don't think it's going to be dramatic or sudden, but I think there'll be a slow creep that we're able to do down the road some more cases which are currently off-label or denied by insurance carriers. I don't think they're going to reimburse us better than they are now for arthroplasty, but I think the indications will be loosened.
Yeah, generally the numbers don't tend to go up. They often tend to go down, don't they? Yeah. Dr. Heise, your thoughts on that? Do you see any change in that in the future, or do you feel similar to Dr. Wright?
I'm very similar. I think they're going to move towards each other. I am concerned that the fusion rates will drop down to arthroplasty rates more so than the arthroplasty rates will go up to the fusion rates. But I do share the optimism that hopefully we'll get to use the devices in a few other indications as we show data in our not in our post-market studies of these devices. There's plenty of studies being done all the time. Publication rate on arthroplasty, both cervical and lumbar, is very high. So we're going to see data out there that we can use to take to the insurers and say, hey, these are other indications where this might be a great option for your patients.
Yeah, and what's sort of ironic in the question that the person had posted was the cost to the system. And I know I've read a couple of papers that show that arthroplasty has a significantly less cost overall in the system, with post-op care, follow-up, return to work, narcotic use, physio, et cetera, et cetera, et cetera. So seems like the insurance companies will make out like bandits all across the board if rates potentially go down. But again, thank you both for this outstanding discussion. Very much appreciated. Thank our faculty, Dr. Adlin, Dr. Heidesy, Dr. Wright. Very much appreciate you guys taking time out of your evening to share some of your knowledge and experience with us. And also thank you to the audience for taking some time away from your evening to share it with us. And on behalf of ZimVie, I would also like to thank Orthopedics This Week for hosting us on this masterclass. Finally, a recording of this masterclass will be available over the next couple of weeks at ryortho.com. So please watch for that. And if you have a colleague that perhaps wasn't able to make it this evening, they can always check out that recording. For any further information, if you're interested on it about Mobi-C, you can also visit cervicaldisc.com or ZimVie.com and learn all about the products that ZimVie has, or about the Mobi-C specifically. But with that, have a good night, everyone. And this ends our masterclass on the subject of why is cervical arthroplasty not the gold standard. Thank you very much, everyone.